Hello everyone, we are now going to go over the peripheral blood flow cytometry from a 63-year-old woman with neutropenia and lymphocytosis. Let's start with CD45 versus side scatter. We have our lymphocytes here with bright CD45 and low side scatter, monocytes here with bright CD45 and slightly higher side scatter than the lymphocytes, and our granulocytes having very high side scatter due to their granularity and dimmer than lymphocyte CD45 expression. And when we see the CD3 versus 7 plot, we see a population here painted in pink that is 7 positive and surface CD3 negative. And one thing that can have this phenotype are the NK cells. So that is confirmed by the presence of 16 and 56. So if we see the 7 versus 1656, we see those pink cells are positive for both 16 and 56. So both 7 and 1656, so those are our NK cells. So those are always there in the circulation and they are pretty minimal, so that should be fine. And when we see our CD3 positive cells, we have a population that is negative for CD7 and a population that is positive for CD7. So let's follow through and see if there are any aberrancies in our CD3 positive T cells. When we see the CD3 versus 5 plot, we see a population of T cells that are negative or dim for CD5. So this subset is negative for CD5, and the cells here have dimmer expression of CD5. So that is not normal. We expect a strong or bright CD5 expression in all the T cells. Having dim to negative CD5 is not normal. And whenever we see this population, we have to start thinking about large granular lymphocytes, or the LGLs, the T LGLs, and those are usually 8 positive T cells. Let's see if these are 8 positive. We see 4 and 8. We see that all these cells are 8 positive. So yes, so these could be LGLs. LGLs are surface CD3 positive. They have CD2, 7, and dim to moderate CD5 expression, or sometimes even negative CD5 expression. And if we follow through, these cells have dimmer CD2 expression, and they also have a dim to negative CD7 expression. They are negative for 16 and 56. So 16 and 56 can be positive in LGLs. They are the NK cell associated antigens, but there are cases of LGLs that express 16 and 56. They won't be completely negative, but it's not like usually distinctly positive in LGLs all the time. They can be positive. And again, these are kind of similar plots in different combinations, and these cells are negative for CD10. So if we get something like this, most labs will add another tube, which is called the LGL tube, or the large granular lymphocyte tubes, which has additional markers like CD57, CD11C, CD27, and CD28. Some labs will also have 16 and 56 in these tubes to analyze different combinations. So now in this tube, if we see the CD3 positive cells, we have the cells that are painted in orange here, which are probably CD4 positive normal cells in the background. So let's ignore that for a while. And our cells of interest are CD8 positive. And if we see the CD8 positive cells, if you remember from the previous tube, our neoplastic cells or aberrant cells were we cannot actually say neoplastic or aberrant. We just know that those are LGLs. These LGLs, they showed loss of CD5, so we have that here. And when you see CD3 versus 57, all these cells express bright 57. So that's something that LGLs have. And these cells also express 11C when you see in 11C versus 57. And one other thing that we see is loss of 27 and 28 in these cells. And that again, we see here, these are showing loss of 27 and 28. So they have the effector T cell phenotype of LGLs. So the final diagnosis in this case turned out to be large granular lymphocytic leukemia. And LGLs, when you see in the peripheral blood, the only thing you can do, or even in the bone marrow, the only thing you can do is to report how many LGLs you see and what phenotype they have, and you can say correlate with TCR, or T cell receptor rearrangement, PCR, to see for clonality. You cannot call them neoplastic, or you cannot call it leukemia just by flow cytometry, because there are certain criteria for LGL leukemias. For example, these need to be persistent for 6 months, and there should be no other reactive etiologies identified, and there should be more than 2%, more than 2,000 of these cells circulating in the peripheral blood, and they should have associated cytopenias and organomegalies. So all these things you have to have to call it as leukemia. So just by flow cytometry, the only thing you can establish is if you see a population of LGLs, and if it is a considerable percentage, and then we report that percent, and we say correlate with T cell receptor PCR and clinical presentation. So then they'll go back and see if PCR turns out to be polyclonal or monoclonal, oligoclonal, and they'll follow up to see if the patient has any autoimmune disease that is causing LGL expansion, or any other reactive conditions that is causing LGL expansion. And when they rule out all other possibilities, they will call this as leukemia. And this is also an indolent leukemia, so clinicians usually take their time in making this diagnosis. Thank you.